Welcome everyone. I want to show how pharmacists approach rational pharmacotherapy. And in this case, I want to show my vision because I want to see educated patients around the world. And how can I achieve it? By being a co-character in internationally recognized patient education programs. And this is why I believe that I always have to learn new things, new ways. So this is why I'm here, even though I have a PhD. But for now, what are my specific goals? First, I want to show how to add on some agents, and second, how to avoid some agents to show that rational pharmacotherapy has many, many fields, and some are really opposing to each other. But first, let's start with the adding state. And here comes nabiximols, and whether it should be used in spasticity of multiple sclerosis. We have already an accepted material in the current neuropharmacology. But what is the topic? Around 2.8 million people have multiple sclerosis around the world, and from them, around 28% have spasticity, which responds not really well to the therapies. On the other hand, here comes nabiximols, which is a fairly new agent, but it's a cannabinoid, and yes, it's not really light. Therefore, nabiximols is still not an elementary agent in the symptomatic management of multiple sclerosis, even though it is an accepted medicine in some countries. So, the clinical question, does nabiximols improve the symptoms of multiple sclerosis associated spasticity? And we believe, yes, it can. We started our meta-analysis from around 3,000 articles and achieved 14 eligible articles with fairly good coherence kappa, fairly good agreement. And here is my primary outcome, the responder rate in spasticity numerical rating scale. You may notice that we have many subgroups because there are many study designs. So this is why, even though we have 2.41 odds ratio as a pooled effect size, we should not accept it as this is the present state, even though if we concentrate on the way of the effect, in every single case it's visible that nabiximols improved spasticity. So after all, we should state, or we can state, that nabiximols is good against spasticity. Further, secondary outcomes also underlines this, and especially if we concentrate on the significant effects. So, our greatest strength is that we could underline the efficacy of nabiximols based on randomized and blinded clinical trials, but we have many limitations, not to mention the differing study designs. So the conclusion is pretty simple. Spasticity can be used in the symptomatic management of multiple sclerosis associated spasticity as an add-on agent. And this is the practice implication, but for research we need stratification. What population, which time frame we should use this agent. Some may notice that there were some symptoms that can be said as a sole symptom. And yes, multiple sclerosis is not just about spasticity. It has many symptoms which needs treatment, some kind of treatments. And if we use more and more drugs, we should face with more and more interactions. But here comes nabiximols again, which could be used as a multi-target agent. So, does nabiximols improve multiple sclerosis-associated symptoms further than which were already in its indications? And our hypothesis is yes, it can be used. And yes, we could use nabiximols against a set of agents. We had a substantial agreement and achieved 53 articles. And now we have some preliminary results. From them, this subject's global impression of change is a really feasible one because it's a global parameter. And again, all studies point to one direction, even though we have a low heterogeneity by statistic result, we should not accept it and concentrate on the fact that all studies point to one direction and then state that nabiximols can improve the global state of a patient. Also, I should mention that nabiximols have a 1 month trial period as its indication. And in this 1 month, we have seen that around the proportion of improvements was around 0.25. But after 1 month, there's some increase in this proportion. Even though there's a great overlap in its confidence intervals, I must highlight that there may be new studies, or there should be new studies, when we try to evaluate what is the real cutoff point for this primary improvement. So, the greatest strengths, this is the first comprehensive meta-analysis of secondary outcomes, but again, we have same limitations as before. The practice implication is nabiximols can be utilized as a multi-target agent in the symptomatic therapy of multiple sclerosis, but again, stratification is needed. My third topic is this LACTAD study, which is about breastfeeding advices on OTC medicines. Why it's a topic? Because all of us know that medicines might pose danger to the baby or decrease breast milk. It's not a good state for the mother. But the undue rejection of medicines is also disadvantageous for the patients. So, even if we are under a medical counter, we have to consider these two topics. But what about the state of the over-the-counter medicines? Where is the supervision? And in this case, the supervision generally on YouTube videos and other websites with diverse informations, with more and more diverse information sources. So we believe that we should make a multimedia platform for these mothers. But how to teach the mothers? This is our first question. And yes, this is the clinical question as well. What is the most effective way, what is the most effective media to educate lactating women on the use of OTC drugs? We believe illustration is the best one, but whether we are right or not, we could state that we can achieve a higher kind of knowledge on OTC medicines. We already started protocol drafting, and our primary outcome would be the knowledge transfer itself. Here's the state of our protocol, and here is the already mentioned pilot phases, materials, illustration, and video contents. And as a summary, I must state that in every single case, I needed evidences. This is why I am here, and I believe this is why we are here as well. And for my additional activities, I've done a lot of stuff, but I want to highlight this one. The development of clinical pharmacy. we already achieved an award, namely General Education Development Application 2022, and we already achieved an audience award as well from a conference and invited to EduIdea. Thank you for your audience.
Is there any well-established knowledge about the mechanism of the nabiximol in this case? I mean, is it the usual, mediated through cannabinoid receptor, or it's an off-target? And maybe one more point, independently of the mechanism, since the cannabinoid receptor is targeted, we can expect a lot of drug interactions on CNS. Did you experience this, or what is the relevance of this interactional profile? Thank you.
First of all, how it really acts is, yes, in truth, it's not really known, because nabiximols itself is a complex of CBD and THC. Therefore, we do not wait only the effect of cannabinoid receptors. This is one point. And interactions, yes, we have to face with interactions. How far is it a problem? It was not mentioned in the clinical trials. I only know a little about the side effects, which was generally the dizziness, and this was the most important side effect, because other are various way how patient reacted to the medication.
Concerning your second publication, you mentioned there that nabiximols improves significantly the CGI-S scores. And my question is, how does it look, a questionnaire of SGIC? So does it contain any related parameters, subjective or any other measures? Are they interactioning?
The subject's global impression of change is generally 1 to 7 score, and patients asked about how you feel from the starting point. And some may ask how you feel your spasticity, some may ask how you feel as a general, but the global impression of change is always try to expect a general change. From these answers, we generally have, and in most cases, I could extract those patients with more than just a minimal change. And the data here are those with at least substantial change what they felt. So this is why an odds ratio, what we can see here. Could I take a snapshot how it works?
How much it depends on mood, for example?
Yes, it depends. It's a subject's reaction, how they feel. So mood is especially a problematic factor. Even though I must say that because in most cases we have more than just 20 patients, and after all we achieved around 1,000 patients in the whole group. There may be some truth behind this, especially because minimal change were excluded.
So how you included the crossover results in your?
If I remember well, we take the total number of the patients. And this is how we calculated with this. We talked about it, that it's not the best how we can treat it, but in this case we decided on this method.
Thank you very much.